I would say against that, I would argue that if you stay in one place, you develop the trust and the relationships that will allow you to innovate.
Mm-hmm.
And what's happened is with the heart monitor, we call it ECG, but the heart monitor, it shows your heart rhythm.
Yes.
When we get a catheter close to the heart, we have these sensors that can tell us that. So when they would go to surgery or radiology, they would get a live x-ray, we call it fluoroscopy, where they can see all the vessels.
Right.
We now can see it on an EKG, which has allowed us to bring those procedures to the bedside. And believe it or not, when you take the magic of the procedure out of it, all vascular access is a needle and a wire into the vein. And after that, it's just moving things over that wire.
Yes.
So it's become much easier to do these procedures safely and carefully at the bedside.
And these patients now receive care when they continue to pull their catheters out of their bodies.
Yeah. So again, I work at St. Joseph's. We have the most complex vascular population, the complex patient population that any clinician that wants to learn could dream of. And we've had patients that, like you mentioned, they're pulling their lines out. They can't get their antibiotics. They can't get their nutrition, or they can't get their dialysis.
Right.
So I had heard early on in my career that doctors in radiology, very rarely, would tunnel catheters to your back.
Your back.
So it will come out on the back of your scapula or down here on your back, out of reach of the patient.
Yeah.
So, I went to the chairman of surgery. I asked for permission to try this on one of our patients that they were going to put on hospice, which is end of life, care to keep people comfortable, because they couldn't keep his dialysis catheter in. He was going to essentially, pass away because of a catheter.
Right.
I called the nephrologist. I said, let me tunnel this to the back. She said, okay. We did that, and he lived for another year and a half.